Hello, my name is Anne Hook, and I'm the Publications Manager at Lymphoma Action. And I'm delighted to be joined by Wendy Osborne, who's Consultant Haematologist at the Freeman Hospital in Newcastle. Hello, Wendy.
Hello, Anne. Lovely to see you.
Today, we're going to talk about patient-triggered follow-up or remote monitoring. And can I start by asking you, what is patient-triggered follow-up?
So I think that we have two main ways of following up our patients. One is by giving planned fixed appointments at fixed times and at a certain time interval apart. And then the other is having more of an open access approach so that if our patients have symptoms or have any concerns, then they contact us and we arrange to see them, usually very quickly, because we're reacting to one of their concerns. So it's led by the patient saying when they wish to be seen, rather than just routine appointment after routine appointment.
And we're calling it patient-triggered follow-up today. Are there other terms that people might hear?
So I think patient-led follow-up is another term that tends to be used as well. There are many other terms sort of in different hospitals, but those are the most common. So patient-led follow-up, patient-triggered follow-up.
How does this differ from the follow-up appointments that people will have had and be used to having?
So I think that probably many years ago, if we saw our patients and completed their treatment for lymphoma, we would give them a routine appointment, so maybe every 4 months or every 6 months at a fixed time in clinic. And we started to realize that it was very unusual for our patients to wake up that morning with symptoms which were causing concerns on the day of their follow-up. And what we were recognizing was that patients would either turn up on that follow-up appointment without any problems, or they would be telephoning us in between appointments because they had new symptoms and therefore had to be telephoned we had to see them at a different time point. So it therefore became quite sensible to actually let our patients be in control about when we are seeing them, because so much of our management depends on symptoms. So when we have a patient on active surveillance or watch and wait, it's all about their symptoms. So therefore, our patients, when they have symptoms, should be guiding us about when we should be seeing them so that they're able to get on with their life in the meantime.
And who is likely to be offered patient-triggered follow-up?
So we tend to use this more often for our patients with low-grade lymphoma, because many of these patients, the commonest low-grade being follicular lymphoma, would be seen maybe once or twice a year, long-term, because we do this active surveillance because we know that many patients don't need any treatment and only need treatment if they have symptoms. So for many patients with a low-grade lymphoma, we make sure that we give them our contact details and give them flexibility to contact us if they develop any symptoms. For our patients with high-grade lymphoma, the follow-up period is usually much shorter. So some centres discharge patients at 1 year because it's that first year where there's highest risk of relapse. Some centres follow up at 2 years and discharge at 2 years, but in that second year, maybe only need to see or telephone that patient once. So I do think that actually, although we've been using this more and more for low-grade patients with low-grade lymphoma, now there is starting to be a move that if our patients with high-grade lymphoma have any problems, obviously they have fixed appointments for fixed scan assessments, but with high-grade lymphoma, we can also move them onto this patient-led follow-up approach.
And you mentioned about people with low-grade lymphoma, and some of them will be on maintenance therapy. Could you be on patient-triggered follow-up if you're on maintenance?
Yes, of course, because usually, certainly where I work, our patients on maintenance therapy, whether that's with obinutuzumab or rituximab, they're coming up every 2 months for their antibody injection or infusion, and they are often seen by our chemotherapy trained nurses at that point. And generally, unless there's new clinical problems, they don't need to also then come to clinic. So we have a process whereby if there's any concerns or problems, our patients can contact us and we can see them in our lymphoma clinic. But otherwise, we won't be routinely seeing them in clinic unless they have any problems.
Now, does the GP play a role in this? Would you be sending people to the GP to have blood tests, for example, if they're on patient-triggered follow-up?
So I think it really depends on what type of lymphoma our patients have, because for the majority of my patients with lymphoma, I don't do any blood tests on follow-up. We have good evidence for many subtypes of lymphoma that blood tests aren't actually a good way of picking up any problems, and that for most patients, it's all about symptoms. So for patients with Hodgkin lymphoma, high grade, follicular lymphoma, if they haven't ever had bone marrow involvement, these patients, we should be seeing them or speaking to them if they have new clinical symptoms of significant weight loss or drenching sweat. And so therefore, for these patients, blood tests and routine imaging isn't part of their follow-up. It's about clinical symptoms. There are occasional patients in whom I do monitor blood results. And for example, that would be patients with a paraprotein, which can be associated with low-grade lymphomas such as Waldenstrom macroglobulinemia. So for these patients that I'm monitoring blood tests, I have to say that I am usually checking those once or twice a year in my clinic, where they get the bloods done in clinic. Now, for some people that live a long way away, then occasionally, yes, they have them done by their local general practice. Obviously, there's demands on local general practice as well. So I do think that if I'm seeing my patients to do bloods, then we always have open access for them to come and see us if problems out with appointments. But for my patients in whom I'm doing a paraprotein check, which isn't many patients really, they tend to come to clinic on a once or twice a year basis.
So for those that are on patient-triggered follow-up, how will they know that something's changed, and what should be the trigger for them to get back in touch?
So there are main symptoms that I warn my patients about. So one is significant weight loss. So it's not changing a few pounds here or there. I don't ask my patients to weigh themselves. If patients are noticing that their clothes are starting to fall off them or they're having to buy new clothes, then these are the patients in whom I would be wanting them to contact us and to see. And the same would be for symptoms of significant sweat. So drenching sweat, needing to change the bed sheet, feeling as if somebody's chucked a bucket of water over you when you're in bed. If those are happening regularly for a week or so, then I would want to see that patient as well. Now, everybody sweats at night, everybody's a bit hot and sticky at night. And so it's not wanting to cause anxiety if people have these symptoms, it's if it's really drenching sweat. Mm-hmm. And then the third main symptom would be if they notice any abnormal swelling or lymph gland that has changed. Now, again, for our patients with low-grade lymphoma, if it's not bothering them or if they're not getting other symptoms, we still would keep our patients on active surveillance, even if they have increased swelling in their neck node, for example, because we know that the lymph node swellings can be quite fluctuant in nature, and we know that there is only benefit of treatment for our patients if they have associated symptoms. So if it's just a small increase in size but not bothering my patients, I wouldn't necessarily want them to contact us. But if it was causing more symptoms, then we would want to see them. And then finally, if people are just non-specifically unwell, so they're feeling significantly more tired, or they've just got additional things that they want us to be reviewing them for, which they think could possibly be related to lymphoma, then this would be a group that we would be happy to see in clinic. I think if it's getting to the point where my patients are worrying, I would rather that they just picked up the phone and we see them. How it works where I am is our patients have direct access to our clinical nurse specialist telephone number, and they contact them and we just add them into our next clinic appointment. So it's usually within a week that we see our patients. Obviously, if there's an emergency, there's a 24-hour access number as well. So I think that if it's getting to the point where they're getting really worried, then just pick up the phone, and we would prefer to see, I would definitely prefer to see my patient at that point rather than have them wait a month or two when they're really anxious and stressed and worried, where actually these symptoms may be completely unrelated to the lymphoma, and I'm able to reassure them.
Yeah. And is there any merit in people, when they first notice a lump, actually making a note of it and the date that they notice it, or is that really not necessary? What's your thought on that?
Yeah, so I think it's a balance of being aware of any change without this awareness becoming intrusive into my patients' lives, because we know that there are so many people, particularly with low-grade lymphoma, who never need any treatment. But what we don't want is for them to spend their many years of life being anxious and worried and fretful about something that may never cause any problems. So I think having a general awareness, but not becoming so over analytical about everything that then that causes associated anxiety.
Are there any risks of being on patient-triggered follow-up?
Personally, I don't think so. I think that if I had low-grade lymphoma, I would prefer to be on a patient-triggered follow-up approach, because I would want to be seen if I had symptoms. And my fear about us giving out lots of routine appointments is that each time we are potentially wasting a morning or an afternoon of that patient's time when they could be doing something else. Because I know that when my patient walks in the room, if they say to me, "Oh, I feel fine," and I say, "Have you got any weight loss, drenching sweat, or any other concerns," and they say that they're fine, then I'm not going to do anything. I'm not going to start scanning them. I'm not going to do any blood tests. It's so rare for me to pick up something examining them that they haven't noted themselves. So I think that as long as patients have a phone number to contact, that they know those symptoms that we've just discussed, then I personally find it a very safe approach.
Can I ask about late effects? How would late effects be monitored if we take this approach?
So again, it would depend upon the late effects that we are concerned about. So that would depend upon which first line or second line treatment the patient has had. So for example, if they've had radiotherapy involving breast tissue, then they would automatically be put into a screening program as part of the NHS screening system. If they've had radiotherapy affecting their thyroid gland, then we would be checking their thyroid function once a year, and that's usually managed in general practice. So each late effect potential should be addressed at the certain time point. Now, obviously, if there's new symptoms that develop, for example, a patient has new symptoms of breathlessness and you're worried about their heart function, then that new symptom would be a trigger for them to ring us so that we could see them.
People have questions that I suspect they ask when they go to follow-up appointments. Things like, I fancy having a massage, is that safe? Or I'm thinking of traveling abroad, is it safe for me to go to America, for example? Those sort of questions come up, and I think in a follow-up appointment, they're quite a natural thing. How can people address that sort of question if they're on patient-triggered follow-up?
So again, really the main recognition has to be that our patients can contact us at any time point. So our patients regularly contact our clinical nurse specialist to ask them questions exactly as you have stated there, or to ask them if they need a letter for their health insurance, for example, or advice about travel. And so 9 times out of 10, the brilliant nurse specialists that I work with answer all of these questions, and the patient doesn't need to waste their time driving, parking in the hospital, sitting in the waiting room. They're answered over the telephone. If there's a question that they need the doctor to get back to them, then either one of our medical team will telephone the patient back, or if we think we need to see the patient, then we'll arrange for them to be seen in clinic.
Now, we talked a lot about physical well-being and patient-triggered follow-up. What about emotional well-being if people are struggling emotionally?
Yeah, so I do think that for our patients with additional psychological support, then the majority of my patients probably use different support mechanisms, such as our hospital psychologist, or we have a Maggie's centre. I know that many of them contact Lymphoma Action for that additional patient support. I think it's very difficult in the lymphoma clinic, certainly, The good news is that we have so many more lines of therapy for our patients, and the treatment options have vastly improved over the last 5 years even. But the negative of that is that it's made the clinic busier. And what I'm finding is that the time now is, certainly in terms of the lymphoma clinic, is mainly spent on discussing treatment and treatment decisions and assessing response to treatment, rather than any additional emotional and psychological support that is tending to now be being accessed in outside of the actual physical lymphoma clinic. So I think that if my patients are needing that additional support, again, I would urge them to contact our clinical nurse specialist, and they will be able to either make those referrals to psychology or signpost them to areas to obtain that opportunity.
If you're on patient-triggered follow-up and you really don't feel you're liking it and you're feeling very insecure about it or whatever, is there an option to say, can I go back to the regular sort of follow-up? Is that an option that people might have?
It certainly where I work it is, and I think that we have to get that balance between making sure that we are available or seeing our patients enough to make them feel comfortable with a different approach. And I do find that I have some of my patients who initially want to be seen face to face, and then after sort of a couple of years with this approach, then they're happy to maybe move to a fixed telephone appointment, sort of touch base contact, and then move fully to their patient-led follow-up.
Is there a length of time, for example, if somebody's on patient-triggered follow-up, they've had no reason to get in touch for 2, 3, 4 years, is there a time when they're no longer on that? They're sort of really out of the system, or is that not the case?
Yeah, so we know that the longer that a patient is between ever needing any input or treatment, then the less likely there's ever going to be a problem due to their lymphoma. So certainly for my patients with high-grade lymphoma, diffuse large B-cell being the commonest, or Hodgkin lymphoma, we do discharge our patients at 2 years completely. And at 1 year, we really move them more to this patient-led follow-up approach for that final year. So they can ring us if there's any problem. We may give them one contact telephone appointment in that second year. I think for our patients with low-grade lymphoma, it depends on how much treatment they've had, if they've ever needed to be treated. Because we know that, for example, for follicular lymphoma, 20% of patients will never need any treatment. And as years go on, many patients feel more confident that they are in that group, that they've still got very indolent disease that doesn't need treatment. So I have to say, at the moment, the majority of my patients with low-grade lymphoma, we still have them in our system. We know that I have a few people who have said that they just want to sort of be discharged formally, and that is fine. And I just say to them at that point, if they could just contact their GP if there's any problems. The GP gives us a ring directly because we know the patient and we'll see them very quickly.
Will patient-triggered follow-up affect somebody's ability to get, for example, travel insurance? Does that have an impact?
It possibly does, because we know that for travel insurance, they want to know the grade of the lymphoma. So, for example, if a patient has high-grade lymphoma with curative intent treatment, the travel insurance is often less once the patient is a few years out of treatment than just 1 year out of treatment. And for people with low-grade lymphoma, usually the fact that even though people will maybe never need any treatment, the fact that they still have an indolent lymphoma in itself, that is usually what is affecting the travel insurance, rather than the fact that they have a patient-triggered approach for their follow-up. So I think this is something that should be discussed in with each travel insurance company. So generally, the patient, it's more the indolent low-grade diagnosis which is affecting the insurance, rather than the fact that they are having a ability to contact the unit directly.
I suppose, in summary, what do you feel are the real benefits to people on being on this approach?
I think that the main benefit for my patients is that they aren't fitting their life around 6-monthly appointments where it is extremely unlikely that at that appointment is going to be the day when symptoms develop. So the problems are usually going to happen out with clinic, in which case they're going to ring up anyway, and we're going to see them at a different time point. So certainly my patients who like this approach definitely feel that they're not dreading the next appointment. They don't get pre-appointment anxiety, but yet they have the safety blanket of knowing they have someone to contact if they ever need to. I also am very conscious that our clinics are busier. We've now got many more lines of therapy, which is fantastic progress for our patients with lymphoma. But because of that, the clinic appointments are getting shorter for patients. And sometimes I fear that the well patients who don't need any input because they're clinically well and just on follow-up, they may sometimes feel rushed, and therefore their experience and quality of experience isn't maybe as good. And that's because obviously we are wanting to focus time on, unfortunately, patients who do need input, do need chemotherapy, may have relapsed with their lymphoma. So I think that with the combination of the two, as long as there is communication, as long as our patients know they can contact us at any point, it seems to work well for the majority of my patients. Obviously, there's always exceptions, and that needs to be discussed within your team, but that generally is the outcomes that we are finding. I think that the message is that the outcomes for patients with lymphoma are now becoming better and better because we have newer treatment options. And there are so many patients who we either obtain cure with first-line treatment or never need any treatment at all. And my fear is that we are impacting their life in a negative way by bringing them regularly to hospital appointments when really the lymphoma, we should be fitting in around them if they have any problems. So I think that that is sort of the main message that I would want to give, is that there's a lot of life after any lymphoma treatment or after a diagnosis of lymphoma. And with clear communication, I would hope that that would improve that option for our patients.
Lovely. Thank you so much, Wendy.
Thank you.